Hi, I'm Justin Riley. Today on Wisconsin Doctors, reflux disease in the neck and throat. We're going to learn a lot today. We're going to learn the difference between laryngopharyngeal reflux and gastroesophageal reflux disease, also known as LPR and GERD, respectively. We're here at Fort Healthcare, and we've got a great team of folks that we're talking to, including Dr. Michael Anderson, who is an otolaryngologist, also known as an ENT, or ear, nose, and throat doctor, and Kathy Pazak, a speech and language pathologist. We'll learn about treatment and, more importantly, how to recognize these symptoms of these diseases. It's all coming up right here on Wisconsin Doctors, so stay right here. Welcome back to Wisconsin Doctors. We are at Fort Healthcare. We're filming in a new location, which we're really excited about, and we are discussing today reflux disease in the neck and throat, and I've got a fabulous team here before me to talk more about that. We have Dr. Michael Anderson, who's an otolaryngologist. Welcome.
Hi. Thank you.
And Kathy Pazak, who's a speech pathologist. Welcome.
Thank you.
First time on Wisconsin Doctors.
Yes.
Well, we're really excited to have you, and there's a lot more to reflux disease in the neck and throat than a lot of people, even I, was aware of. So I want to start by asking the really tough question to Dr. Anderson here, and I'm going to see if I can pronounce this. What is laryngopharyngeal reflux, also known as LPR?
Well, Justin, that's a good question. I get that question a lot because I see a lot of people in my office who really don't know about LPR or laryngopharyngeal reflux disease. In order to really understand LPR, you need to understand what's known as GERD, which is generalized gastroesophageal reflux disease. That's the GERD. And if you think about it, all GERD really is stomach acid coming up from the stomach into the esophagus. So that's known as gastroesophageal reflux, just means a backflow up into the esophagus.
Sure.
Well, LPR is when that stomach acid doesn't stop in the esophagus, it comes all the way up to the voice box or the throat region. So the esophagus connects our mouth to the stomach, and if stomach acid comes up all the way to the voice box area, then we start to see manifestations of LPR.
And what are some of those, just curious, what are some of those manifestations that you're talking about?
The most common two symptoms I get in my office, and it almost occurs daily, is people will have trouble with their voice, and that's when I oftentimes have to get Kathy involved, or they will come in with a sensation of a lump in their throat, particularly right at the base of their Adam's apple, kind of in this region. That's what we call a globus sensation, and it's very common in people who have LPR.
Interesting.
Yeah.
Wow, I never knew that. So we've talked about the differences between LPR and GERD. How common are these types of diseases, and how often do you see them in patients?
I see them almost daily.
Almost daily, wow.
I think population-wise, Kathy probably has a pretty good idea of the true numbers and stats,
Sure.
but I definitely see it every day in my office.
Sure. Are you working, how does that work? Do they then refer to you then for if they need speech pathology or speech help?
The first line of defense is always a medical management. I mean, Dr. Anderson will give the patient, medications that will control the GERD, but then if their voice is still rough or hoarse, or they still have problems with their voice, or if they have problems swallowing, then he'll get us involved. He'll get the speech therapists involved.
Okay. And you, Dr. Anderson, you talked a little bit about some of the symptoms. You said people will feel like they've got sort of a lump in their throat, they'll have issues, their voice will sound hoarse and that sort of thing. Are there any other symptoms that are typical of either one of these? Are the symptoms different? Are they the same?
There are a lot of different symptoms. Okay. Throat clearing is a lot. That's a big symptom that I see. Chronic sore throats. A lot of times people will go to their primary care physician and be seen for a sore throat that's been persisting for several weeks, and they'll be told it's a virus, but then they don't get better, and then they eventually get referred to my office, and lo and behold, we discover it's reflux disease.
Wow,
So,
okay.
sore throat, hoarseness, globus sensation, throat clearing, I see those a lot.
Yeah.
Kathy alluded to swallowing difficulties. That certainly can play a role as well.
Right, absolutely. Well, we're going to take a short break here, but when we come back, we're going to talk about some of the treatment options for these reflux diseases in the neck and throat. Don't go away. There's more Wisconsin doctors coming up right after the break here at Fort Healthcare. Stick around. Welcome back to Wisconsin Doctors. We are here at Fort Healthcare, and we're talking about reflux disease in the neck and throat. And before when we left off, before we went to commercial break, Dr. Anderson, we were going to discuss a little bit about treatment of some of these things. But I think first, we should really talk about diagnosis. What is the process for diagnosing some of these diseases?
Well, that's a great question, Justin. Almost always we can diagnose this with just a physical exam in the office after talking to somebody. And if we could just look at this model, and just real quick to kind of explain this. This right here is the thyroid cartilage that sits in the front of our neck. It's commonly known as the Adam's apple. So this would be my Adam's apple here. Now right behind our Adam's apple is the larynx. So if I just spin this around, this is the actual voice box right in here. So this is the area that we need to look at in the office, is the actual voice box, the larynx. And how we do that is we do a procedure in the office where we have a 4mm scope. It's a fiber optic scope. It looks like a long piece of spaghetti, if you will.
Oh, wow, okay.
And we can put a little bit of cotton in the nose. It numbs up the nose, and we can place that scope through the nose, and the scope will come. If we spin this back around, the scope kind of comes down from above and goes right into about this area. This is the epiglottis right here. The scope sits right above the epiglottis, and you can clearly see the voice box quite easily.
Wow.
And you can see the vocal cords. And the typical signs, the typical signs that you will see is redness and swelling in the back of the voice box. A lot of times you'll see cobblestoning, what we call cobblestoning. That's, if you can think about those old world European walkways that were made with cobblestones, oftentimes they were red in color, and it will look like a cobblestone walkway. You'll see that in the back of the throat by the voice box, so not necessarily in the back of the mouth, but further down, kind of in this area. And that is known as cobblestoning and can certainly be a sign of reflux disease in the throat or the larynx. So once we have the symptoms and once we see the signs, that's when we're pretty certain that we're dealing with laryngopharyngeal reflux.
Are you able to determine, I'm just kind of thinking about this, are you able to determine the difference between somebody who has, cobblestoning or some sort of other irritation because of LPR or GERD, and somebody who may have it for a different reason? Like, there's people who abuse their voices. I mean, is it possible to have something like cobblestoning happening just because of abuse of the voice box?
Well, you can have cobblestoning. Cobblestoning is just a sign of inflammation. So say if somebody has seasonal allergies that are really bad, they can have cobblestoning. If somebody has a viral infection, they can have cobblestoning. So cobblestoning is just a general sign, but obviously the symptoms will be much different with those other processes than with LPR.
Right, okay. And so that, from there, you can kind of determine what the necessary treatment would be once you determine that this is LPR that this person has.
That is correct.
Well, I want to make sure that I give you enough time to talk about that, so we're going to take another short break here, and then we come back. This time we're going to talk about treatment of LPR and GERD. We'll be right back with more Wisconsin Doctors right here at Fort Healthcare. Stick around. We've been discussing reflux disease in the neck and throat here on Wisconsin Doctors at Fort Healthcare, and we've talked a little bit about what the symptoms are and how to diagnose them, and how they're diagnosed, I should say, but I'd like to talk a little bit about treatment. So, Dr. Michael Anderson, can you talk a little bit about how LPR and GERD are treated?
Yeah, absolutely. So when most people come to my office, I'd probably say the number one symptom we have is hoarseness. That's what really bothers people the most.
Sure.
And drives them into our office. So typically, once the diagnosis has been made, we trial those people on a course of medication known as proton pump inhibitors. And these medicines are designed to reduce the amount of stomach acid that is produced. So therefore, if you have less acid, hopefully you have less reflux, and the problem will subside. So typically it involves putting them on a course of medicine for 1 month. And then we typically see them back and see how they're doing. If they're doing well, we cut down on that medicine with the hopes of getting them off of it. If people continue to have hoarseness, or if they have severe hoarseness, even with the treatment, as they are getting treated, oftentimes I will refer them to the speech pathologist, Kathy, and then Kathy will do her own evaluation and treatment course of somebody with LPR and hoarseness.
Okay, so you are kind of treating the hoarseness part of it. You're treating the causes of that hoarseness, hopefully,
Correct.
and then you're kind of treating the hoarseness itself.
Right. I'm treating the voice disease.
The voice disease,
The voice
right.
problem.
Okay.
If you try to work on someone's voice who has GERD without the medication,
Right.
they're not going to get better.
They're not going to get better.
So we have to treat the disease, and then I can treat the voice. I can work with. We have different behavioral strategies that we use to improve someone's voice. We, teach them unfortunately, it's lifestyle changes, and it's easy therapy. It's 1 or 2 visits, and the patient gets better. And if they don't get better, then they go back to see Dr. Anderson, because then, there might be something else. Their medicine might not be working well. But hoarseness, you use your voice for your work.
Right.
And anyone who has a hoarse voice, you don't have to live with that. You don't have to live with that scratchy, painful voice. It's so easy to change. It's so easy to fix if it's GERD, if the problem is LPR, if it is GERD. And we like to see the patients in the clinic. We do an extensive history of, when does your voice good, when is it bad, how does the patient feel about their voice? That's really important, because if it doesn't bother you, if it doesn't hurt, then it's okay.
Right.
But if someone answers the phone and they always think it's the male in the house and not the female, or if they are in a social situation and it's hard to talk, their voice gets tired by the end of the day, and they start to be a little more isolated, then of course we want to work with that person. You don't need to live like that. You don't need to live with that. Speech pathology and voice disorders, it's more of a quality of life. We want to improve your quality of your life, and we want you to be out and active.
Absolutely. I mean, I think there's so many studies that show that isolating yourself and cutting off either incoming or outgoing communication is so detrimental to people's health, mental health, emotional health, physical health.
Absolutely.
So that's fantastic. I've been kind of thinking about this. Why do you think LPR is sometimes not recognized?
Probably because we've always had it. It's like one of those things that
their
you've always
normal.
had. Yes.
Yeah.
And it's called the silent reflux, because it's not necessarily, patient doesn't necessarily have heartburn, really. And, they might a little bit, but, it's after, that big meal.
Sure.
And so you just live with it.
Yeah.
And it just, keeps going on, and it doesn't have to.
Right.
Oftentimes, Justin, before we even put people on medicine, we always talk to them about their diet, their dietary habits, foods, caffeine, chocolate, heavy meals, particularly late at night, all contribute to reflux disease. And these are very hard habits to change.
Right.
And so I just don't think there's the awareness of reflux disease, certainly not reflux disease of the throat or voice box, that people are aware of. So a lot of it goes kind of under the radar. And when you really start to peel back the dietary changes that may be necessary for a patient, it becomes very enlightening to them. and then they understand the process, and it's very helpful.
Which is why we always do a really extensive history.
Sure.
You know, like Dr. Anderson said, you talk to the patient, what's going on, when does this happen, and then you get a better feel for what they're doing out of the clinic, and then you can help them in the clinic.
Get a good picture of their lifestyle, in
Exactly.
other words. I'm just curious, can you name a couple of foods that might lead to, you know, LPR or symptoms like that?
Citrusy
Pizza.
foods, pizza,
Late night pizza.
Really? Okay.
Definitely.
caffeine, chocolate, peppermint, all the good stuff.
Really? Okay.
Alcohol.
Good stuff. Okay. Well, we're going to take a short break. When we come back, we're going to continue talking about age ranges and some other considerations for reflux disease in the neck and throat right here on Wisconsin Doctors at Fort Healthcare. So stick around. Welcome back to Wisconsin Doctors. We've been talking about reflux disease in the neck and throat here at Fort Healthcare. And I'm wondering if you guys can expand on the range of ages that might have GERD.
Well, that's a good question. I get that question fairly often, and I would answer it by saying, if you're alive, you can have it. So
Okay.
we really see it in newborn and infants, all the way up to the elderly. My main population that I deal with is anywhere between teens and adulthood and up.
Okay.
I don't see a lot of small children with it, although can be in young children. The population I see it, if it is affecting young children, is with chronic sinus disease, because it can play a big role in that. That's a whole nother topic, but
Right.
but I do see it in kids. But I know Kathy deals with it in infants.
Yeah. You want to talk a little bit about that?
Sure. The highest incidence of GERD is in babies
Okay.
and in the population like over 40. Does that make sense?
And
Wow.
that's
Babies and over 40.
Yeah. And 25% of babies have GERD or have some kind of reflux disease, and the speech pathologist gets involved because we're the feeding experts.
Sure.
So, you've got the little baby that is crying during a feeding.
Right.
That, what do you do? They're not
Right.
supposed to cry during a feeding.
Right.
So that's one of the symptoms. Another symptom is really bad vomiting.
Yeah.
Not just we call them the happy spitters that just
Yeah.
have a little bit of dribble. No, this is pretty significant vomiting. And when babies refuse to eat, then there's something wrong.
Right.
This is what they want to do. They want to eat. So the speech pathologist gets involved, and sometimes babies go on medicine. I mean,
yes, they do.
you do the same thing for them as you do for adults, except the best thing to help a baby with GERD is gravity. Gravity is
Really?
our friend. You got to sit them up. You got to sit them up.
Okay.
You got to have their head higher than their feet when they're
Okay.
sleeping. And so I work with families, and new moms are very, very worried and very upset. Their baby's crying during eating. It's very stressful.
Sure, yeah.
And so we just tell them you have to feed the baby more often, and you got to hold them more and
Yeah.
hold them upright.
Yeah.
Yeah, a lot of times, and I've had 3 children, so if you're faced with a baby in the middle of the night, they're hungry, obviously parents are exhausted at that point.
Right.
So it's very common to feed the child, and then you lay them right back down. Well, what Kathy is saying is the laying it down, you neutralize gravity. So gravity really helps us keep stomach acid
Yeah.
in our stomach. Like when we're sitting upright like this, but when you lay down, gravity is neutralized and doesn't help.
Right.
So if you feed a baby and then you lay them right down in their crib, that baby could potentially reflux.
Right.
Because
Yeah, that
just
makes
because
sense.
gravity isn't helping.
It seems so logical too. I mean, but people don't even think of that, I suppose. So.
And babies always sleep better in their car seat or in their swing.
Yeah, they
and
do.
just elevate their head just a little bit. And same
Yeah.
thing with adults.
Yep.
That's one of the best things to do, is just to elevate
Just to
your head.
elevate. So, talk to me a little bit about how you, as a speech pathologist, work directly with an ENT like Dr. Anderson.
Dr. Anderson would see the patient. If he determines that the patient has any kind of a voice problem, not necessarily from GERD, but from other problems, then the patient would come to the speech pathologist for treatment.
Okay.
And our treatments could be behavioral, they could be, exercise. It's always developmentally appropriate because we treat the age span. And our disciplines work together very well. I mean, we complement each other.
Yeah.
His treatment helps mine and my treatment helps his. And we have happy patients.
You clearly are kind of operating on the same wavelength. I've gotten that sense from talking to you both here today, so that's good. That's good. So, other than what we've talked about a little bit today, can you? We've just got about a minute left, but can you talk to us really quickly about some of the other services that you do provide at Fort Healthcare in terms of ear, nose, and throat issues?
Sure, be happy to.
Okay.
In addition to reflux, basically my practice involves anything from the neck up. So the most common things I treat are sinus disease, allergies, ear infections, stuff like that.
Okay.
Yeah.
Okay. And if someone suspects that they might have GERD or LPR or even need your services at all, is that something where they would need to go see the first step would be to see their primary care physician and then get a referral to you?
They certainly can do that. They can make an appointment with us directly too.
Okay,
That's
great.
fine, too.
That's good to know. So make an appointment directly if you suspect that you have LPR, GERD, or any other issue that might involve the ear, nose, or throat. Dr. Michael Anderson and Kathy Pazak, thank you so much for joining us today.
Thanks for having us.
All right. That's all the time we have for Wisconsin Doctors. Can't believe we're out of time already. Thank you so much for joining us. From all of us here at Wisconsin's 57, we are inviting you to live longer and live better. We'll see you next time.